So patients with atrial fibrillation AFib are at a high risk for stroke, and it's typically recommended for most AFib patients to use stroke prevention drugs, commonly known as the blood thinners, especially the direct oral anticoagulants DOACs, as a lifelong therapy. So, however, these drugs increase the risk of bleeding, and it can be very challenging for patients to adhere to medications over a long period of time. So left atrial appendage closure or occlusion (LAAO), using a device such as Watchman offers an attractive alternative to lifelong drug therapy for stroke prevention. But there is very little evidence on how to best select patients for left atrial appendage closure. So the traditional research approach relies on subgroup analysis, often based on a single factor such as age, sex, or comorbidities like heart failure or kidney disease. And this approach has limitation because the subgroup analysis is subject to false positive, meaning if you test many different subgroups, some some subgroups will by chance be statistically significant. And subgroup analysis is also subject to false negative because the sample size can be very small for some subgroups. So, as a result, because there is very little evidence, there is some variation in routine clinical practice regarding how to select patients. From a prior survey we did among American physicians, we found, well, there is some consensus, such as most clinicians would consider patients with a history of major bleeding for left atrial appendage closure. There are some significant variations in their opinions for other aspects. For example, some physicians might consider end stage liver disease, end stage kidney disease, or poor patient adherence or refusal to oral anticoagulants as reasons for considering LAO, while other physicians actually view some of these conditions as contraindications. So, additionally, one patient might have multiple factors that could be both the reasons for considering LAO and also the reason for withholding LAO. For example, if a patient has a history of intracranial bleeding, that could be a reason for LAO. But if the patient, or often these patients are older adults, so the advanced age is sometimes considered a contraindication to the procedure. So it's very tricky. So that those are some clinical challenges for patient selection in routine clinical practice. Often the machine learning models we see is to predict an outcome such as 30-day readmission or procedure complications. So here the question is actually in the treatment effects, meaning it's not the outcome, but the difference in outcomes between the two treatments. So that's why we use a causal machine learning framework called causal forest. So this causal forest is a generalization of the popular random forest method. So the traditional random forest method splits the data with the aim of minimizing the error in predicting the outcome. By contrast, the causal forest splits the data to maximize the treatment effects between the three nodes while minimizing the treatment effect within the nodes. So basically, what it does is it clusters patients into different groups. So within a group, the treatment effect is similar, while the treatment effect is different for patients in different groups. So this method reduce the problem with false positive and false negative with the traditional subgroup analysis. And this causal forest method can also take advantage of the complex interaction and relationships among multiple patient characteristics, such as age, sex, and other comorbidities. So our paper develops this machine learning algorithm, and this algorithm can be implemented in routine clinical practice to alert primary care and general cardiology to say, hey, this patient might be a good candidate for left atrial appendage closure, consider referring it to subspecialties. So why this is important is that most patients with atrial fibrillation are actually routinely managed by primary care or general cardiology, but these physicians or clinicians are not super familiar with the procedure. So this algorithm can serve as a decision support tool to help them refer the right patient to the right subspecialist. And in the U.S., there are actually very limited, a relatively small number of subspecialists, meaning the interventional cardiologists and electrophysiologists in this case. So I think this algorithm itself, when implemented into routine EHR, can have great implication for patient management and improving patient outcomes. But I don't think physicians should rely on the findings or the tables to select the patients, because we provide um, some top patient characteristics that might contribute to the potential benefits for LAAO. So we provide those tables to enhance the explainability of the machine learning algorithm. But the modern machine learning algorithm, they are not like the traditional risk scores that you take a look at 5 or 10 patient characteristic and you make a decision. Actually, this machine learning algorithm uh, incorporates over 100 patient characteristics and incorporates complex interactions among them. So the patient characteristics in the tables are just serve as a way to illustrate what does the algorithm see. Um, but one shouldn't be directly just looking at those patient characteristics alone and make clinical decisions. So in our study, we found patients with advanced age and certain comorbidities are more likely to benefit from LAO in comparison to the direct or anticoagulants. We illustrate those patient characteristics in table 3. But there are a few considerations when you interpret the results. First, we define the treatment effect as the absolute risk reduction, not the relative risk. The difference is that, say, if an intervention reduces the risk from 4% to 2%, that's half the risk. It's actually a big reduction in relative term, right? But when you talk about absolute risk reduction, it's only from 4% to 2%. So basically a 2% absolute risk reduction, not so much. So when we use the absolute risk reduction as the outcome, you can imagine patients who benefit, meaning having the largest risk reduction, will certainly have a higher event rate at baseline. They are typically the people with advanced age and more comorbidities. So that's why you see those patient characteristics. The second consideration is that adherence to medication is low in routine clinical practice. And some of these patient characteristics in table 3 might be predictors for poor adherence to drugs, which is the alternative treatment to to left atrial appendage closure. So when patients do not adhere to the drugs, the procedure LAAO is typically more beneficial. So some of these characteristics might just be the predictors for poor adherence. But this algorithm is still very valuable because the purpose of the algorithm is to tell the clinician in routine clinical practice whether the patient is a potential candidate for the procedure. So predicting the response to the treatment in routine clinical practice should include the consideration of the adherence to the alternative treatment, right? So the third consideration is, in our study, who benefit more would depend on how you define the endpoint. So our primary outcome is a composite outcome of stroke, bleeding, and mortality. As you can imagine, bleeding is fairly common. So if you have more bleeding at baseline, you are more likely to bleed during follow-up regardless of the treatment, and the bleeding might mask the benefit you derive from the reduction of stroke and mortality in some patients. But we also provide other tables for the top predictors of the benefit for mortality. We couldn't do it for stroke because the event rate for stroke was too low. Yeah, so the machine learning algorithm definitely needs more validation, evaluation, and implementation research. So traditionally, when researchers develop a prediction model, they typically do so from one cohort and then use retrospective data from another institution to validate. And if the performance is good, then you're good. However, this approach is somewhat outdated. um, so here we actually use a large national cohort to develop the model, and then we are validating the model in local health systems. So we are training it in more broader, in large data sets, and validating and adapting the model in local health systems. And eventually, modern AI will be more like a drug or device. They can have significant implications on patients' treatment approach and outcomes. So, because of the high stake, we need a large trial to see whether implementing these algorithms in practice will improve patient outcomes. Because running this algorithm often require advanced IT infrastructure, data storage, and computational power, as well as ongoing efforts to monitor the performance of the algorithms. So likely, eventually, we will need a trial to see whether implementing this algorithm actually makes a difference.